So a very good evening to everyone. I'm very excited to present to you something which is for the first time in India, a new molecule. And this is trilagliptin, which is being introduced for the first time over here. It's available in Japanese context, but in India we are bringing it the first time. See, the basic issue which we want to address over here is that controlling glycemic variability is a major concern, and trilagliptin can really do this very beautifully in a very systematic and smooth fashion. So there are various anti-diabetic molecules and other molecules available as once weekly therapies for the management, like trilagliptin is one as a DPP4 inhibitor, omarigliptin is another one. Then in GLP-1 inhibitor or receptor agonist, if you say, exenatide, dulaglutide, semaglutide, and once weekly insulins are also available like Icodec and Afcitora alpha. So the purpose of all these molecules is to bring in the proper variability control, and certain trials have been conducted on very specific standard deviation control as a primary endpoint, which we'll be discussing further. Trilagliptin is a very novel molecule which has been engineered uniquely to give a very long half-life, and the aim was to create compound with improved pharmacokinetic properties, allowing for a very less frequent dosing, that is once in a week. If we see the kinetic graph of this molecule, it is commensurating with the inhibitory concentration. The inhibitory concentration for DPP4 inhibition is very, very low. The lowest amongst all, it is 0.465 nanogram per ml. And if you see the, after 7th day, the levels are still 1.67 for trilagliptin in the plasma. That shows that it remains active till the last, and the steady state concentration is 21.6, which is much above the required concentration to inhibit DPP4. So the slower dissociation from the DPP4 enzyme is another unique characteristic. For example, if you see sitagliptin or vildagliptin, they have in few minutes, like 2 minutes or 3 minutes, the molecule gets dissociated. Whereas in case of trilagliptin, it is more than 30 minutes. So this is very like long association with the DPP4 enzyme. Trilagliptin is having a very unique pharmacokinetics. You see the Cmax is around 437 nanogram, and terminal phase is in the range of 2 to 3 nanogram per ml, which helps in maintaining the control of inhibition of the DPP4 enzyme. And the primary excretion is through the kidneys. If we see the inhibition as far as the half-life is concerned, 54.3 hours is the one for trilagliptin, whereas all others, including omarigliptin, teneligliptin, vildagliptin, sitagliptin, they are much smaller half-lives. So trilagliptin is indicated, of course, for management of diabetes mellitus, and since it is primarily excreted through the kidneys, for standard patients like without any kidney ailment, it is 100 milligram per day. But in case of mild renal failure, where there is more than 50 of the CCR clearance, you need not do any kind of dose adjustment. For moderate, where it is 30 to 50, 50 milligram once weekly, and in severe renal failure, you can have where it's less than 30 ml per minute, you can give 25 milligram once weekly. But it can be very safely given. The trials are there on all these dosages. There is no incidence of hypoglycemia, or you can say very low incidence as compared to any other. So for example, in case of sitagliptin, it is 1 to 10%. For linagliptin, it is more than 10%. These are the incidences of hypoglycemia. Here, in this case, it is 0.1 to 0.5. It is not 5, it is 0.5%. In the special population like impaired hepatic function, pregnant women, lactating women, we have to be careful. Otherwise, there is no dose adjustment required in case of hepatic failure. When it comes to the contraindications, we say in case of severe ketosis, as you always don't give SGLT4, SGLT inhibitors or DPP4 inhibitors. So in severe ketosis, diabetic coma, pre-coma, type 1 diabetes, you should not be giving Trilagliptin, but rather switch on to insulin. In case of severe infection, elective surgeries, etc., you should also switch over to insulin for the management of diabetes. When we come to drug-drug interactions, you see if you give any hypoglycemic drug, it will have an add-on effect. So we avoid that. And in case of those which attenuate the hypoglycemia, for example, if you give adrenaline, corticosteroids or thyroid hormone, there we have to adjust the dose accordingly. Now, we conducted clinical trials on Trilagliptin. More than 3,000 patients trials are available. So to begin with, for the phase 1, the kinetic was studied, and it was seen that the kinetics which is falling in place with the expectations, and the values of our as well as the Japanese molecule which was originator from Takeda, that is Zephatec, it is similar. Then we come to phase 2. How the dose was decided. The dose was decided based upon like 25 milligram, 50 milligram, 100 milligram, 200 milligram. If you see at 100 milligram, the efficacy has peaked out. There is no more effect with the 200 milligram. That's why the dose is limited to 100 milligram once daily. Indian experience also shows that there is 1.25 gram reduction of HbA1c when it is more than 8 gram % of the HbA1c level to begin with. So it is very effective in all the Indian patients. The study data is very promising. Once weekly Trilagliptin versus Allogliptin was studied in Japanese context, and that too in double-blind phase 3 non-inferiority study, and the results are very promising. Trilagliptin was non-inferior to Allogliptin given once daily. So once daily versus once weekly is similar control. Similarly, long-term and safety and efficacy for weekly oral Trilagliptin versus as a monotherapy or in combination. So when we say in combination, we can see that Trilagliptin has been used in combination with sulfonylureas, with glinides, with the alpha-glucosidase inhibitors, biguanides, and thiazolidine-dione analogs. So these are the drugs where you can easily combine Trilagliptin and bring in the good efficacy for the patients. So efficacy and safety in type 2 diabetes in severe renal impairment, as we discussed, here the dose which we'll be using is 25 milligram, of course. So with a 25 milligram, this is the graph. If you see, for the first 12 weeks, it was given as placebo control. And when it was switched over from 12 weeks onwards, you can see the rapid reduction. It was switched over back to Trilagliptin. So this drug is very, very effective as soon as you start administering in the patient. Again, we'll have another real-world study of retrospective study, which is in 7,200 patients. And you can see that once weekly Trilagliptin brings in almost 80% achievement of HbA1c below 7 gram %, and whereas others, when you give OD or BID, the efficacy is like 70 or odd %. We have another study of Trilagliptin in combination with insulin therapy. So you can combine insulin also in some patients, and this phase 4 data is similar. You can see that it was again a crossover study. And for the first 12 weeks, it was placebo controlled, and later on it was given as combination, and you can see the control was consistent. Another randomized control study with Allogliptin, and this is one study which I would like to emphasize upon. because here the focus, the primary endpoint is the reduction in the glycemic variability. This is a very rare incidence that when primary endpoint is considered as the glycemic variability. But in this case, trilagliptin has shown very significant reduction in the glycemic variability as compared to allogliptin or any other once daily kind of DPP4 inhibitors. So as far as safety is concerned, the meta-analysis data is available with us, and this clearly shows the scoring over of trilagliptin over allogliptin, sitagliptin, linagliptin, teneligliptin, anagliptin or vildagliptin. As far as the one of the concerns that what about the beta cell functioning, trilagliptin helps in improving the functioning of the beta cells also. Clearly mentioned through the HOMA 2% marker, and there was a significant improvement in this particular marker with trilagliptin group. Then the quality of life parameters were studied with this molecule, and it is very clearly seen that there is definite improvement in the quality of life, and various tables were used for this, which I am just skipping for the reason of the time. And the adherence is very important. Since it is improving quality of life, adherence is 97% in case of trilagliptin group. It is a very easy thing to switch over from any existing DPP4 inhibitor to trilagliptin, and the study were conducted to show that without any problem or without any associated increase in the glycemia, you can easily switch over from existing OD or BID therapy to once weekly therapy. For the convenience of the patient, the company is providing with a QRS scanning. Once you scan with the app, it keeps on reminding patients every week to take the drug. So that is a very helpful thing for the patients. And there is another study when satisfaction and efficacy, when you are switching over from daily to weekly, again a very good satisfaction or improvement in satisfaction level is there. So to summarize the advantages of and unique features, its once weekly administration is very like it reduces the pill burden, then high selectivity, easy switchover, low risk of hypoglycemia, potent DPP4 inhibition, improved quality of life, followed by minimal self-monitoring. Even CGM studies have shown consistent efficacy, reduced glycemic variability, that is number one point in favor, higher target HbA1c achievement, potential cardiovascular protection, improved beta cell function, and long-term safety data. So this potential cardiovascular protection is because of the micro and macrovascular improvement, and it has been seen that risk of atherosclerosis is also reduced. Thank you very much for your attention.